Good morning, everyone. Welcome to breakout session number 2. We're so glad you guys can join us this morning to learn more about the menopause journey, navigating the twists and turns with a trusted compass. We have a fantastic panel for you all this morning. Please join me in welcoming first our moderator, Karen McNew-McGuire, Senior Consultant at Carilion Clinic Department of Communications, Marketing, and Planning. And give me a warm round of applause, please. And then our panelists include Dr. Sarah Evans, Assistant Professor, Division of Urogynecology at Carilion Clinic, Dr. Heather Greer, Assistant Professor and Academic Specialist in General Obstetrics. Thank you. Obstetrics. I'm not a healthcare professional, apologies. And gynecology. Joined also by Dr. Amanda Murchison, Associate Professor, Academic Specialist in General Obstetrics. Oh, what about I'll just say it twice? Okay. And gynecology at Carilion. And lastly, Dr. Jennifer Wells, Director, Women's Mental Health Division of the Department of Psychiatry and Behavioral Medicine at Carilion Clinic. Give them all a warm welcome.
Thanks, everyone, for joining us. Are you having a good time here today? Yes. That didn't sound like you're having a good time. Are you having a good time? Yes? Good. Much better, much better. So we're here to talk about some things that probably don't get talked about as much as they should, and so we're happy that you're here. So we're going to start just with some of the basic Q&A type things. So the first question for our panel is, how do I know when I'm in menopause?
Good question. So by definition, it's basically when a woman has been for 12 consecutive months without a menstrual cycle. So it's a kind of a retrospective diagnosis. And this is a natural part of the aging of our life, and it ends our reproductive years. So the ovaries are no longer making eggs, and therefore there's very low levels of estrogen and progesterone. And a lot of times patients will present with hot flashes, mood swings, emotional lability, vaginal dryness, insomnia, and it's typically at age 51 to 52 in the U.S., and a lot of times patients think that they need blood work to determine where they are in the menopausal transition, but it's actually not necessary to make the diagnosis. We will occasionally collect it if we need help in making the diagnosis.
What is hormone therapy?
I got that one. So it's medications that we prescribe to menopausal patients to help alleviate those symptoms that I discussed, like the hot flashes, vasomotor symptoms. There's an array of estrogen medications that we can use, and it can be included with progesterone or without progesterone. It can be also administered in an oral route or a transdermal patch. There is lots of evidence that shows that it is effective. Estrogen is effective at treating the vasomotor and vaginal symptoms.
I think we wanted to use this opportunity to talk a little bit about sort of the buzzword bioidentical, because I think that's something that you hear a lot and I think can be really confusing for people. So bioidentical, that term is used to mean that the estrogen or progesterone is chemically the same as what our body would naturally produce. And so there are bioidentical estrogens and a bioidentical progesterone that is FDA approved. So that means it's gone through studies and sort of gets that stamp of FDA approval. And so probably for us on the panel, that would be the type of hormone therapy that we would really mostly talk to our patients about. There are bioidentical hormones that can be compounded as well. And so this means that we're using a pharmacy that's sort of putting together a hormone therapy for you. But I do think it is important to understand that compounded hormones are not FDA regulated. It doesn't mean that they don't play a role in menopause therapy, but it's important for you to know and to be able to advocate for yourself that the dosing of those hormones have not been through the same rigorous studies. We don't always know with a compounded hormone if you're getting the same dose in each treatment of the hormone. So there are both compounded availability and FDA-approved availability. And so it's just, I think, important that you understand that terminology. Do you want to?
Sarah, did you want to speak now?
Yeah, this could be a good time to jump in. So then another, a later question is, what are the symptoms of menopause? And I think Amanda or Heather already touched on many of these, but one symptom that women don't always know is related to menopause is how it can affect the bladder. Pain with urination, frequent urinary tract infections, even pain with intercourse, vaginal itching, vaginal dryness, vaginal burning. A lot of women come to see me not realizing that these are actually symptoms that are related to menopause and to the lack of estrogen. And so these hormone therapies can be effective in treating these symptoms, but usually using a local topical product, whether it's estrogen or there are non-hormonal options, are more effective at treating those symptoms. And when we talk about, who's a good candidate for hormone therapy or not, the topical local estrogen creams, tablets, and rings, I think are safer for more women, and we can talk about that kind of going forward.
Can we say one more thing? I think
Of course.
many women may understand this, but perhaps not everybody does, is that when we think about hormone therapy, we're often talking about estrogen and progesterone. So if you still have a uterus, you have to have a progesterone component to your therapy, because when I think of estrogen, I think of it as the fertilizer. It allows the uterine lining to grow a little bit, and progesterone I think of as the lawnmower. It keeps the lining really thin. So if you have a uterus, we can't give you something that allows the lining to grow a little bit without putting that lawnmower effect there, because otherwise we're putting you at risk for uterine cancer. So if you have a uterus and you're talking to your provider about hormone therapy, there's always going to be a progesterone component to it. There are some therapies that have combined, like an oral pill that's combined. Oftentimes, providers separate the two because, quite honestly, there are more options that way, and it's usually cheaper. Progesterone is a very large molecule, and so we often try to really push estrogen patches because they give you a very continuous level of estrogen hormone. We do know that transdermal estrogen, it bypasses liver metabolism. There's lower risk of clotting events like heart attack, stroke, blood clot in your leg that are associated with transdermal estrogen. But progesterone, being a very large molecule, is very hard to deliver transdermally. So you do have to be very careful if you are prescribed like a progesterone cream from a compounded pharmacy, because it really may not be enough to provide that lawnmower effect. So oftentimes we are still really prescribing an oral progesterone because it gets to the body in a level that provides that protection to the uterus. Yeah.
And I might just add one other thing.
Yes, this is I feel like we're learning a lot. I don't know about you guys.
And obviously, we're talking about hormones and the pendulum swings in medicine. And right now, it's swinging more towards recommendations for hormones. But there are patients who have contraindication to hormone therapy or, for whatever reason, elect not to use it. So there are hormone-free agents out there. Specifically, there's 2 FDA-approved medications for that. One of which is an antidepressant medication that increases the level of serotonin in the brain. It's called Paxil. And so that is FDA approved for menopausal hot flashes. And then secondly, a newer medication on the market came out last year called Dioza. You may have seen commercials for that. And that does have some contraindications. So if a patient has liver disease or kidney disease or is on other certain medications, they may not be able to take it. But those are both FDA-approved medications for the treatment of hot flashes.
Would that be someone that has Factor V? Is that something that they take?
Yes.
And that brings us to our next question. Who's a good candidate for hormone therapy?
Again, this is as we continue to study hormones in patients, and now 20 years removed roughly from the Women's Health Initiative or the WHI study, patients that are good candidates for hormone replacement therapy would be someone who is acutely symptomatic. They have a low risk for blood clot formation, such as a deep venous thrombosis, and they're low risk for breast cancer. There is evidence that as long as we use these hormones early in the menopausal transition, ideally within 10 years of the onset of menopause and starting at less than age 60, it's been shown to be preventative for osteoporosis, which is low bone density. It's been cardioprotective, so heart attack, stroke. Also decreases premature death and then helps with hot flashes.
And this might,
Ask a question, sorry.
yeah.
What is the percentage or how common is it when receiving hormone therapy that someone who does not have cancer in their family, it's not hereditary, develops that? Because that happened to my mother. And they think that this is related to her therapy.
Specifically are you talking about breast cancer? Yeah, so this is hard because it goes back to what Dr. Greer sort of pointed out about the Women's Health Initiative study, which is where a lot of our counseling data research comes from a very flawed study. So just to kind of give you an example of what we're trying to pull data from, women in the Women's Health Initiative study were primarily women in their 60s. You were actually excluded from the study if you actively had hot flashes. So, it's not the type of women that we're really trying to initiate hormone therapy in, but this is still the data that we're trying to extrapolate to guide our counseling. And in that study, we have to keep in mind that the risk of breast cancer for everybody in this room is relatively high, right? So, so I think that confounds things too. But probably they looked at the two arms of the study. So the women who have a uterus who are on estrogen and progesterone, and that arm of the study in this flawed study showed about a 1 in 1,000 increased risk, okay? And then the women that were only on estrogen, so it had had a hysterectomy in the past, it actually showed no increased risk in breast cancer. So probably relatively small, but we don't.
I don't know if it's worthwhile to jump in, but I think the simple answer is we really don't know.
Yeah.
The impact of hormones across our body, across the timeline of our lives, is very complex. And we don't have it broken down, and science hasn't figured it all out. And so, like Dr. Murchison said, to her point, the people at the time who did the study did the best they could with what they had, but more and more sort of data and women are finding their own way through the menopause transition, and some are taking hormones and some are not. And as we collect more and more of that data, we're learning sort of the earlier on you take the medications might be more protective and also less harmful. The later you do that might be less protective, more harmful. So some of that is related. And sort of from a personal standpoint, I have a mother who took hormone therapy. She had a surgical hysterectomy and took hormone therapy for 25 years. And at 74, developed breast cancer shortly after I did at 45. And do I think the hormones probably played a role in hers? Yes. But was it worth it for the 40 years that she felt great? Probably. So, it's very individual. I don't know if you guys want to add more, but
I have one other thing on it. The Women's Health Initiative was also looking at a specific estrogen and progesterone that we don't commonly prescribe anymore. I mean, it still is an option, but I would say the vast majority of physicians are prescribing a isochemical estrogen medication that is identical to what we used to make in our reproductive years. And so those specific types of estrogens, in addition to the specific progesterones that we are now prescribing, are different than the Women's Health Initiative meds, and they have a lower risk of blood clot and breast cancer.
yeah.
I think this would be a good time to talk about the difference too between transdermal systemic estrogen and vaginal estrogen products, because unlike hot flashes, the lack of estrogen in the vagina and around the bladder, those symptoms get worse as a woman ages. So the farther you are through menopause, those symptoms worsen through time. And so those older women are more likely to need treatment or come, asking for treatment. And while there are non-hormonal options, vaginal estrogen is a very effective treatment option for those women. And we have some really good, large observational data showing that there's no increased risk of breast cancer or stroke in women who are high risk, meaning they've had breast cancer, their mom, their grandma had breast cancer, they have known genetic predispositions to breast cancer, and even in those high-risk women, there's no increased incidence of breast cancer or stroke in women using vaginal estrogen. Now, is some of it absorbed in your bloodstream? Yes. But the question is, how much, and is it enough to really be relevant? And so vaginal estrogen products come with the same black box warning from the FDA saying, this can increase your risk of uterine cancer and breast cancer and clotting. And I think that's important for women to have that conversation with women. You read that and you're like, who would ever use this product? But the fact is that we don't really have the data to support that. And that's very different than a woman who's seeking treatment for hot flashes, because those vaginal estrogen, topical estrogen products will not help with that. But if they're specifically seeking treatment for, we call it the genitourinary syndrome of menopause, which is urinary tract infections or pain with sex, then those vaginal estrogen products can be considered a safer option for some women.
And I want to clarify one thing too. If you're on vaginal estrogen and have a uterus, you do not need the progesterone because there's not enough systemic effect to affect the growth of the lining of the uterus.
And you can be on both. You can be on an estrogen patch and also use a vaginal estrogen, and that is safe.
Question? The question of
Oh, yes.
Sorry, I'm not hearing back there. So what I'm asking is vaginal estrogen. Would you recommend for somebody 70 and over who is still suffering from menopause due to the fact they had early surgery, like mine, was the mid-30s?
Yeah.
And they started me on it, and they took it off because of the danger. But I'm still having, and the other thing is, when you go to doctor's office, I'm glad you brought this up, they rarely ask us, are you still having menopause?
Yeah.
That's the big thing. If we can get out to these doctors, please ask us. Don't assume because we're 70 and over, we don't have these things. So
Yeah.
my question to you, I asked her, would that be a good question to ask Dr. Madison?
Yes, I see women all the time who have been taken off vaginal estrogen due to concerns. You're now 60, you're 70, you shouldn't be on this anymore. And we have no data to support that. And women certainly don't have to be on estrogen. There are non-hormonal options, but women have the right to choose to be, and to be counseled about that as an option. And so, yes, I prescribe it often to women in their 70s, 80s, 90s if they're symptomatic from it. And I think, in my world at least, trying to empower women to know that a lot of these symptoms are related to menopause, because I think that's something we don't always know about our bodies. Like, all of a sudden I have all this pain and I'm getting all these infections, but not really putting two and two together to know that it is related to menopause, to be able to then advocate for themselves to their providers. So yes, I think we need to teach more healthcare providers about it, but I also think it's important to talk to each other as women about it and help educate each other about it.
And our next question, are there hormone replacement alternatives for basal motor symptoms, hot flashes?
I feel like Dr. Greer really already answered most of that. So were there any other? Yes, there's a.
My doctor prescribed me Zoloft.
Yeah.
Dose for hot flashes, and it worked.
Yeah, so as Dr. Greer mentioned, Paxil, which is not exactly like Zoloft, but
Pretty close.
pretty close, sought FDA approval for that indication. But, as is in sort of the pharmacy world, when it came out, came out at a dose that was very specific for hot flashes, like a 2.5 milligrams off or something, which then, was like more expensive, right?
Money grab.
Yeah, so so we as providers often learn sort of how to use medicines that are cost effective. So really, you could, any of the SSRIs.
Yeah, sort of just, on that, when we talked about Paxil has the FDA approved label for it, those of us who are in the medical field or deal with pharmacologic substances, like when you're talking about drugs are variously approved for, one single thing, 5 different things. It depends on what the drug company decides to pursue in their research in order to get that label. Medications, though, are generally built by class and are often very similar by chemical structure and by function. And so, like, I'm glad you said it. It doesn't have to be Paxil at, 6.7325 milligrams in this pretty blue pill that now is called Wimanzi or whatever, some crazy name that they come up with that you see on TV and you're like, oh, maybe I need to look into that, or like Fuchsiology.
With the people dancing, the dancing commercials.
I mean, so, right, like it can be largely probably within the spectrum of all SSRIs. It's worth asking about. I loved your question about, yes, we do need to educate more providers. I really feel like a lot of what I do and the women that I have in my practice as a psychiatric practice who are aging and are noticing will come up on it, mental health symptoms and brain fog, and I don't sleep as well, and I'm fatigued, and my body's changing, and I don't feel all that great about it, Dr. Wells. I then am able to say, hey, let's talk a little bit about menopause. What's it look like for you? How far along are you? Talk to me a little bit about that. Have you mentioned it to your OBGYN? Has anyone told you maybe to look for your urogynecologist? Have you tried these resources? Maybe do a little reading, go online. We have this thing called the internet, and it has so much information, which sometimes as a doctor is a little bit hard to handle, but oftentimes is really fantastic. And so I think, kind of bringing it back, there are many options from a medication standpoint that bridge all of our departments to help women better transition through this stage of life. I say all the time, like, I don't want to pathologize menopause, right? It's not a disease. It's a life transition. Like, we have had many in our time, and we will probably have many more. And there are ways through it. And by educating ourselves, but also reaching out to the medical providers that we have known for a long time, or even new ones that we're introduced to, let's get help for ourselves. Like, it is out there. Preach.
No, that was great, Dr. Wells.
I think you have a couple of questions. I don't know if we have time for them.
I'm so glad that you say that, because I said in the past couple of years, there's been so much information. Like, Winona is blowing up.
Totally agree.
Yeah.
Totally agree.
Right. And so, being able to know what kinds of the right questions to ask our doctors, right? Because I feel like I'm super overwhelmed with all of this kind of buzzwords and terminology that I still don't have a good grasp of kind of what they mean for me. And it also sounds like, which is also a little scary, there might be some trial and error,
Yeah.
right? About
Yeah.
what kinds of balance of hormones would work for me. So there might be some really bad experiences coming up too, trying to figure out what would work for me.
And it's not only what the specific medication is, but then also the dosage.
Yeah.
Right, 'cause it's
So
not-
that's like, not only am I not feeling great, but I could potentially feel worse before I get to the other side of feeling better. And that's also scary and intimidating.
Yeah, I have a question. One thing I didn't expect, I had the hot flashes and, well, thank you, Tim. But is the inflammation in my shoulder and my hip flexors, and that's something that I found out about online. I actually had a cortisone shot in my shoulder thinking that I was doing damage from working out. And my shoulder, as I sit here, it still hurts. It hurts to sleep on my side. And when I at times get up, my hip flexors, I was thinking I was too tight from sitting. And so I don't know if there's other, no one, my doctor didn't talk about that at all. My GYN is not comfortable talking about menopause. What she gave me in my opinion, was not the best. I think it is the standard, here's this, a medication that was $500 a month, vaginal topical cream, and I'm like, are you kidding me? Then I got mad. And then
As you should.
psychiatric meds, and I'm like, no, I'm not trying to get crazier. And so I'm just generally pissed, and I don't think that's gonna figure that out. Is the worst is the inflammation, and so what are treatment options for the inflammation to try to help with that? I didn't realize the inflammation was gonna be so bad.
Yeah, I think that's probably in the top three. I'll just say it, joint pain is probably in the top three presenting symptoms that my patients come to. So hot flashes, probably some mood instability, and then joint pain for those people that are, just entering menopause. And so really just, hormone therapy. So going on, if you had a uterus, obviously we'd have discussion, but it would probably be a recommendation for an estrogen patch and an oral progesterone prometrium to try to help with those symptoms.
But what role does testosterone play?
So testosterone, we have to be a little bit careful with because it is not FDA approved for women in the United States. So that's where sometimes compounding may have a role. I think most of us probably on this panel would not recommend testosterone unless we've really, really kind of tried multiple things. In that case, we can either go to compounding or we can use FDA-approved male testosterone components and try to divide the dose by 10. So there are some options. Of course, as a female, your insurance will not cover testosterone.
Also, we think most of the reason why testosterone works is because it's converted to estrogen. So to me, in my mind, I don't understand how it could really benefit a woman and only kind of presents this kind of black box of I don't really know what's in it or how to appropriately prescribe it without causing harm. So that's why I try to avoid it when ultimately we just want the estrogen to work.
I've been on this journey a long time. Thrown into it in the 30s with a complete hysterectomy and contraindicated for a lot of other therapies along the way. Nothing has really worked. So here I am, 67 years old, 35 years out from hysterectomy, and I still have. Listen, so and when you talk to your doctor, they're like, oh, well, do we need to see a women's health specialist? Is that what you would recommend for like a full workup? Or what would you recommend? Because I've been on the homeopathic, I've been on the prescribed things, I've been on a whole lot of different things, but these symptoms come back all the time. They work for a month or 6 weeks or 8 weeks, and then they're right back. This has been my journey for 30 plus years. So I'm trying to understand who is best to help resolve the repetitive symptoms that don't seem to dissipate. Been there, but don't even help.
Yeah. I mean, it is hard. I mean, I think we do have to be careful as you kind of get past that first decade of menopause. There can be a role for continued hormone therapy. There sometimes can be a role for initiating hormone therapy after that first decade, but then it really becomes much more about risk benefit for each individualized patient. And we also have to make sure at that point, if you are still having hot flashes at 67, it could be related to menopause, but there are other things we definitely need to rule out at that point. Other.
The best type of doctor to rule that in or out.
Yeah.
So the North American, the North American Menopause Society is an awesome resource, and you can go to their website and look for menopause specialists in your area. Certainly starting with an OBGYN seems like the right place, but not, and a little bit in our defense, I mean, we're kind of tasked with knowing everything about women, right? From birth to death, everything in between. We have one little specialty, and we're in charge of everything to do with women, right? Which is a little bit absurd. So within that, we kind of choose the things that we have interest in and specialize in that, but that's not always easy for women to seek out. And so resources like the North American Menopause Society are a great place. I don't know if anybody has any others.
I do. Did you know? I definitely think NAMS, NAMS, North American Menopause Society, is a great place to look. There are other resources online, too, that could help you identify persons that have specialized training for women in menopause. But I also, in the same way I said earlier, like it's not a disease, sometimes there are going to be symptoms that you're going to have for the rest of your life. And I'm sorry. You know, like I clearly you have, right? We're 30 years in. I'm a psychiatrist by trade. I'm a women's mental health specialist. That might be someone to talk to too. It's a lot to carry around, that feeling like you're searching for the answer for 30 years, and maybe we sort of need to broaden our idea around what actually is the answer. Right, it is an aging process. We are all on a journey to the grave, sorry. Just to bring in the bright spot. But part of that, part of that is we grow and change. Like, there are things that are going to change about your body. We're not going to like it, and we have to learn to manage it. I don't have the answer for everything. I have persons who have mental health issues that are chronic and long-standing, and we look to ameliorate, to mitigate the worst symptoms, but sometimes we can't fix it. That's part of life. For those of us, I'm sure I see heads nodding or smiles about our bodies changing. We don't sleep that well at night. I mean, for crying out loud, can I just have 8 hours of uninterrupted sleep? I don't think so. I don't think that's coming back for me. It's okay. I'm going to learn to manage it, right? But like, I don't necessarily want to take a pill, because I can. We do manufacture them, and you'll be in a coma for 10 hours. But like, that's not necessarily, right? You're not treating the problem. We've just developed a way to conk our brains out, and I don't love that. But that's my take, and I don't live your life, and each of us are going to make individual choices, but just bringing in this idea that sometimes we're going to have symptoms that maybe are going to persist, and we're going to mitigate, ameliorate, but not fix. Transition, not a disease. What, darling?
I just said, gee, God.
But I do think, an OBGYN or, a lot of primary care physicians will address menopause too. If you're seeking out somebody new, maybe when you call to make that appointment, ask the front desk, is there somebody in that office that specializes in menopause, so that you're routed to maybe somebody who will be able to address that.
Thank you.
Mm-hmm.
Our next question is about limiting social interaction due to menopause and incontinence symptoms. It can lead to feelings of isolation. Maybe you aren't as comfortable in that setting as you used to be. We wanted to see if we had some suggestions for coping with that feeling. You go from being social and doing all the things to, I just don't feel like it.
It's time for the sunshine to come back in. At some point, like if you look up what are menopause symptoms, there's like 65, right? It's like everything. I mean, really, it's like all living. They should just put, are you alive? But it's true too, to some extent. I can speak personally and I can also speak professionally. Like personally I mentioned, like I don't think a good night's sleep is coming back. I too have joint problems. I have undergone breast cancer and a lengthy treatment for it that, like, I try to blame everything on chemotherapy because that makes me feel better. But likely, it's probably also that little pill I take that modulates my estrogen so it can never go that high. So that means that I don't have any in my body, which also contributes to, inflammation, problems with my GI tract, brain fog, fatigue, sleep, as we mentioned, and then this whole other constellation of symptoms, mood and anxiety, right? Mood instability, a lot of anxious rumination. I think also what coincides with menopause is life transitions, right? So we're aging, our children are going off to college, we're facing a new point in our lives about how do we want to live the next 20 years? Are we keeping the fellow we had? Are we trading him in for a new model? Did we get rid of him 15 years ago and now we're empty nestered? Like, let's fire up the lava lamp and get started again. I don't know, that'll tell you how old I am. It's something about, what is your next, life transition look like? And if you are finding that because of menopausal symptoms, the ones that, my esteemed colleagues have been talking about, that you're going out less or you don't feel comfortable engaging in the world, well, there are products, right? There are medications you can use. There are also products that we all see when we go to Kroger and Food Lion that, can help us feel more comfortable if we have a little leakage, a little laxity, things like that. And then there are also medications from my neck of the woods and also counseling, right, to be able to talk through what it means when you're an empty nester, when your children, leaving has brought about reflections upon the past, and maybe you're remembering things about your life. It is not uncommon for this life transition to bring up some traumatic repression, some problems that might have happened from a long time ago that then might do best in a psychotherapist's office. Or if just the changes in your body are enough to make you feel sad, hopeless, anxious, worthless, then that's where depression and anxiety become a clinical reason to get medication that someone like a psychiatrist like myself might offer. It isn't for everybody, but if it helps, then why not use it? This is can be an incredibly active and vibrant time in a woman's life where a lot of the responsibilities that have been on you for the past 20 years are now removed. And you have a chance to go and explore and decide, what does it look like for you now? And I hate the idea that you don't want to engage or investigate or explore that because you don't feel good about your body or how it is managing in this menopause transition.
Do you want to talk?
Yeah, and I'll add that, when people used to ask me what I did, I always, do I explain what a urogynecologist is? Like, what are the things I take care of? But I do find myself doing that more and more because knowing that there are specialists, to treat urinary incontinence, bowel incontinence, things like that do get worse with time and age. And, there are treatment options, whether it's physical therapy or medication or surgery, that can be life-changing. And it's really never too late to at least seek out some education about the options that are available to you. And I can't tell you how many times women have said a treatment just for urinary leakage has literally changed their lives. And so, I do find myself explaining in gruesome detail what I do more and more because I don't
Great dinner party guest.
Yeah. My husband's an orthopedic surgeon, so he always starts, well, I'm an orthopedic surgeon, and she just lets me take over. But I think, just knowing that there are specialists out there who do offer treatment for these things is important.
Our next question, sexual health, vaginal dryness. Are there ways to help increase libido?
So I think we talked about the vaginal dryness portion. The one thing we didn't mention is that, we talked a lot about different estrogen products available, but there are non-hormonal options to treat vaginal dryness. There are, lubricants to be used with intercourse, but there are also moisturizers that are, women can use who are not sexually active. I describe them like face masks for the vagina. They're meant to be used regularly, like 2 or 3 nights a week, and are really effective in alleviating a lot of vaginal dryness, vaginal burning, painful urination, and pain with sex. And then libido, more complicated. Anyone wants to take that on?
Well, I think the first thing is sometimes just removing the discomfort from intercourse can be a huge step towards increased libido. Nobody wants to do something that's painful. But, and I think this is always a hard discussion to have for people that you don't know really well. As I start to get to know my patients, sometimes they feel comfortable. We feel comfortable together talking about. Sometimes you just need to spice it up a little bit, whether that's reading a erotic romance novel or, watching a little video that sort of kind of spikes.
Swinging by the novelty store.
Yes, yes. So, you'd be surprised when I think your brain sort of forgets what sex is, and then even if it's just reading about it and, it's kind of normalizing it again, can be remarkably powerful. Then sometimes we use medication, so...
Yeah, I'll echo what my colleagues have said, that it's fairly complicated. Libido is both, physiologic and mental, psychiatric. And you have to, sort of honestly search yourself and in discussion with your OBGYN or your gynecologic specialist and maybe a mental health therapist, is there a component that has to do with depression and anxiety? Have your clinical symptoms, right, have the burning, dryness, pain, right, that does over time lead you to not want to engage in behaviors that then it becomes hard to reinitiate. Even if you feel better, you're like, but what if, oh God, I don't want to do that, right? That then becomes something that maybe a psychiatrist or even a mental health therapist might be able to help with medication or just counseling, but it starts with, frank, open discussions with the people you trust. And also, I do believe as an empowered person, you can go try the North American Menopause Society. Brigham and Young has a women's midlife and menopause clinic and website that you can look up. There are a number of groups on social media to look up. There are women, this is the next wave of women's health. And as a women's mental health specialist, I certainly am noticing, you all have, that everybody's talking about it. It pops up probably on your feeds if you're on social media, right? There are a number of places to look, to read, to engage, to see is this me? Is this something that I might benefit from? And if it's not, pull it out. But if it is, or it's of interest, dig in further. And then if you find a resource or you hear something, bring it to your doctor and say, hey, would this be suitable for me? I think libido is complicated, and sort of how I moved earlier to talking about, it's menopause is part of maybe a larger life transition for many women. And when we have life transition, that's a lot of change. Change inherently is hard. Most humans don't do very well, even though it is the only constant in life. That's God or whomever you believe in playing a little joke on all of us. But I think just reaching out and looking for your resources and trying to be honest, okay, would this be a time when I need to speak to someone about options for me? Medication, surgical, therapy, psychiatric.
Yes?
I feel like we have the panel is fantastic. And I work in the mental health field, and I'm used to a multidisciplinary approach. My husband is a cancer survivor. We have a multidisciplinary approach where you have multiple professionals. And menopause feels like with our 6,500 symptoms, is what it feels like. More like, I don't understand why we wouldn't have a multidisciplinary approach, because I'm listening to Dr. Evans, I'm like, I'm going to need you. And I feel like, do you envision the future being a multidisciplinary approach to allow, instead of just one doctor being required to know all of the things, that we can have multiple physicians who are able to help us? Because I think that ultimately decreases healthcare costs.
We're already on it. So I will tell you that part of how medicine was designed was siloed care. And more and more and more, I think probably as everyone in this room has experienced, there is overlap, and often significant. And so part of what our departments are trying to do is to figure out how we bring the necessary people to the table to help these challenging issues. And I certainly believe menopause is one of those. I think oncology is another one that is ripe for discussion. I think perinatal mood and anxiety disorders. Anyone who's pregnant or parenting has dealt with a number of things that could have used a lot of physicians coming to the table. And so we're trying. And I think COVID has offered a great experience with telehealth to sort of maybe see, are there other ways we could make this work? Can we bring other people to the table either virtually or in person temporarily to help expand services that we can offer? But yes, the answer is yes, yes, yes.
We just have a couple of minutes left. Do any of you have any closing thoughts? Something that anyone who's attended today, if they got nothing else from our conversation, that you hope they...
I would say again, the pendulum is swinging in medicine in regards to hormone therapy. So if you are struggling out there and you are low risk, then I really think you should consider hormone therapy. And that can be just a candid discussion that you have with your provider. But so much of our lifehood is in the postmenopausal status or postmenopausal years, and we want them to be good years, and we want to enjoy our children and our grandchildren. And so don't be miserable out there and seek care.
Yeah. Excellent.
I just have a question about that. Is there a way that you can say that you're having the symptoms in a way that will have your doctor understand that, like, I fully feel after many, many years of asking questions, I'm in the beginning stage of it, and I've heard too much, you're too young. So I just kept saying, well, I've got this going on, I've got this, and I don't know, are they related? It sounds like they could be. Is there a way to present that to a provider that they will say, oh, it actually is not all of these separate things together, it could be this.
And in medicine, we love to have a unifying diagnosis. Patients come in with all these symptoms, and we really try to come with a single diagnosis. And so I think, depending on your age, if you're late 40s, early 50s, and you're saying, I'm not sleeping well, I'm hot flashing, I have anxiety, I think that would be a very appropriate way to come into your provider visit and be like, I think I need to talk about hormones. I'm menopausal.
Yeah, or perimenopausal. Yeah, and I think that's my take-home message, is that Dr. Greer said the average age of menopause is around 51 in the United States, but perimenopause, right, can be 7+ years before you sort of have that 12 months without a period. So, and now to confound things even more, a lot of women are using a progesterone IUD as birth control, so they may not have periods at all, and so then it can be really hard to know sort of when you stop having periods. And so I think, to your point, if for women in their 40s who are starting to have symptoms, I think it's okay to bring up to your provider, whether it's your primary or your OBGYN, like, I think I'm starting to struggle with some perimenopausal symptoms. Can we talk about what my options might be? Yeah.
So I want to piggyback on that.
Yeah.
So I'm obviously in a larger body. So how do we advocate for ourselves so that it's not you're too young, or you just need to lose some weight, or whatever it may be? How do we advocate to our doctors? This is what is going on, and you need to believe me.
We are at our time, but I'm so sorry. And then we'll get to you. So and then we'll wrap up.
I think that was pretty direct.
Yeah.
And if you have a trusted provider, right, then they should hear that. And if they don't, then I think you need to think about finding somebody else. I will say, I deal with it a lot, right? People have a constellation of symptoms, and my job is to decide, does that relate back to a psychiatric issue? And, right, people often in our society, it is more acceptable to have physical symptoms rather than mental health symptoms. So the onus is on me to try and parse out, is it the physical, is it mental health? And that's sometimes difficult, and my patient and I might be at odds. But at times, it comes back to, if you keep going back and you're saying, listen, I tried what you said, it didn't help, then your provider needs to take a deep breath. And I've had to do that, right? I've had to be like, okay, I don't live in your body, right? Lived experience, I cannot match. So let's work on where we need to go next. And if that is a specialist, right? So if you need to look at the NAM's website and you need to find a person who you believe is a perimenopausal specialist, or saying, hey, could you recommend a book to your provider, right? Do you know enough about it? I'm going to read this book, and then highlight the book and bring it back. Be like, this is the book you gave me, and here are the things. I don't want to put all the onus on you, right? Your job isn't to educate a provider, although sometimes that happens. If you can't get through, go somewhere else. If you can, and I have found this, there are times I don't know, I don't know everything. I don't get it right every time. I have to be like, okay, I don't know. Let's find somebody who might, and actively work with your provider to find a path forward.
Okay, and then we have one more question.
Not a question.
Oh, okay.
Great idea, mental health. I've always been women with PTSD. I will tell them to mention this to their therapist. That is such a great thing you just brought up, and I will spread it for you. Thank you very much.
Well, thank everyone for taking time to attend today. We hope you enjoy the rest of your day.